Good morning, everyone. Welcome to day 3 of the SOFT first SOFT 2020 virtual conference. We are glad to have you here today. It's also the second in a series of 3 professional panels that SOFT is hosting for the conference. And we appreciate you all coming today. I'm going to be turning it over to your host for the day. Before I do that, I just want to do a little bit of housekeeping, let you know that you can find obviously more of our events over on our website at trisomy.org. All of our attendees are muted, as you're probably very well aware. You may have questions as we go through today. If you do, feel free to write them down so you still remember them. Come question time, we'll hold questions to the end. But you're able to raise your hand at the end, and at that point in time, you'll be called on unmuted so that you can ask your question. If you prefer not to do it that way, you could also put it in the chat if you would like to just have one of us deliver the question. So with that, we are ready to roll. And I just want to turn it over today to Dr. John Carey, friend of SOFT, and someone we appreciate. It was his vision to put this panel, this series together, and we just appreciate that we are. So I turn the floor over to you, Dr. Carey.
Thank you, Terry. So welcome, and thank you for joining us. As Terry mentioned, this is the second in a series of 3 seminars on medical care aspects in trisomy 13 and 18. Today we have 2 outstanding speakers whom I actually know and have worked with over time. Tomorrow, just to alert you, same time, same station, that is 2 o'clock Central Time, Dr. Megan Weaver and Dr. Nicole Burge of Nebraska Children's University of Nebraska will talk about their program, which they call Heartland Cares. And you may know Dr. Weaver is head of the palliative care division there at the Children's. So I welcome everyone here today to think about attending tomorrow. But today we have online, as I mentioned, 2 authorities, 2 experts in their area. When I came up with the idea for this, I thought the common theme was really the advances or better understanding of the care of newborns and infants with trisomy 13 and 18. So I invited my colleague that I work closely with at Primary Children's, Dr. Shaji Menon, and Dr. Glenn Green from University of Michigan, who I've known for years and has had a chance to hear him speak in the last 2 years on his topic. But let me introduce both of them, and then I'll have Dr. Menon go first, and then Dr. Glenn Green speaking on airway issues going second. So Dr. Menon will speak on pediatric cardiology. You'll see his beautiful title slide in a moment. Shaji is the Associate Professor of Pediatrics in our Department of Pediatrics at University of Utah, Primary Children's. He's also an Adjunct Associate Professor in Radiology, and he will soon be a full professor at our University of Utah. Among many other positions, he's the medical director of the Pediatric Cardiology Single Ventricle Program, which is also of great service. He is my go-to person when someone's coming, what I learn about with either 13 or 18. He's always kind enough for me to be able to get them into his schedule. And of course, a lot of the parents already know his work in our region. So without further ado, Shaji, I'll turn it over to you.
All right. Good evening, everyone. I'm going to share my screen and hopefully, can everyone see my screen? All right. So good evening, everyone. And thank you, John and the SOFT team for giving me this opportunity to share some of my thoughts regarding cardiac care of patients born with trisomy 18 and 13. It's really a privilege to work with these patients and families, and I have learned a lot from John over the years, and this is really a pleasure to be here. So I'm going to talk about cardiac care in infants with trisomy 18 and 13, and how some of the issues surrounding decision making. Okay, I have no disclosures. Just to give you a little bit of background, after trisomy 21, The second most common aneuploidy is trisomy 18 and 13. The prevalence of trisomy 18 in live-born is about twice that of trisomy 13. It's 1 in around 6,000 in trisomy 18 and 1 in 12,000 in trisomy 13. There's a really high incidence of fetal demise and miscarriage in this age group. So when we see them as in the fetal clinic, we try to convey that. The 5-year survival based on one of the recent publications in 2019 in trisomy 13 is about 10%, and in trisomy 18 is about 12%. But I suspect that the survival data will change based on the changing paradigm of the care of these patients, because I think still we are not completely or optimally taking care of all these patients, and I will come back to that in a minute. And the other thing that is important to remember is the babies who survive the first 4 to 8 weeks of life, they have a completely different survival curve than those who are born with trisomy 18. So the first couple of months are really critical time period for these patients. In terms of cardiac defects are very common in trisomy 18 and 13. Oftentimes they are referred following a diagnosis by the MFM because they saw on an ultrasound whether some features, nuchal translucency, or other features suggest you have trisomy 13 or 18, or a non-invasive blood test was done in mother where trisomy 13 or 18 was picked up, and they're referred for cardiac screening. The incidence of heart disease is about 80 to 90%. The common defects are ASD, VSDs, and polyvalvular disease, although about 10% of them can have severe heart disease like tetralogy of Fallot, double outlet right ventricle, AV canal, coarctation, or single ventricle heart disease. One of the key things to remember is that majority of the early death that you see in trisomy 13 and 18 are not due to cardiac defects. Over the years, even through my training and through my time treating these patients, there have been a paradigm shift in the care of trisomy 13 and 18 patients. We have gone from do not resuscitate to full resuscitation, no cardiac surgery, to increasing numbers of cardiac surgeries performed across the country and across the globe. There are many pioneering institutions outside the United States who are also involved in excellent care and cardiac care of these patients. And initially our thought was there is hardly any benefit of cardiac surgery, but now we know that cardiac surgery, when performed in appropriately selected patients, improves survival, improves home care, and improves quality of life. And I'll show you some data to support that. However, despite this, a significant proportion of healthcare providers still believe that it's futile to offer cardiac surgery in patients with trisomy 13 and 18. So let's talk about prenatal cardiac evaluation. Once a diagnosis or suspicion of trisomy 13 or 18 arises, I think it is critical that those patients undergo a comprehensive prenatal or fetal cardiac evaluation. This is recommended because of the high incidence of heart disease in this group of patients. The second reason is because this provides an opportunity for multidisciplinary counseling. Oftentimes these patients have multi-system disease or multi-system defects, and multiple specialties can come together to discuss the outcome of the patient and the care of the patient. This also provides an opportunity for consultation with a cardiac surgeon if there is a cardiac defect present that needs surgical intervention. It is important for decision making whether the family wants to continue pregnancy, pursue comfort care, or termination of pregnancy in a timely manner. And as you know, the termination guidelines are different in different states and different parts of the country. It is critical for delivery planning. And if the center in which the baby is born is unable to take care of these patients, transfer to appropriate centers may be needed. Also, it is important to discuss centers' willingness and expertise in cardiac surgery or intervention, because I think these are inevitably questions that are going to come up after the baby is born. And I feel like having these discussions before birth really facilitate the process after birth. One of the things that I really want to emphasize is that there are some things that we really should avoid saying to these families and patients when we interact with them. You'll be surprised to see, and I will show you some data that we still hear these words being spoken in care of these patients. One is trisomy 18 and 13 is incompatible with life or is lethal, which is not true. Anyone with a Google or a cell phone, smartphone can Google that. Patients will have a life of suffering. Again, it's not true. The word vegetable is used often in reference to these patients, which is, in my opinion, absolutely wrong. Replaceable, right? You can have another child, destroys family, nothing can be done. All of this are far from true. This is one of my patients, Aaron, and I'm using this picture with his permission, and you can see that's a patient with trisomy 18, and there's a vegetable in comparison. So there is no comparison between the two, and we should avoid using those lingos. In terms of cardiac surgery in trisomy 18 and 13, if the patient has a cardiac defect that is non-ductal dependent, like a VSD or AV canal, the important thing to recognize is that these patients do not need surgical intervention soon after birth. You have 2 or 3 months to wait before a surgical intervention is needed. So oftentimes, cardiac surgery is not the priority. As Dr. Green will speak after me, airway issues, breathing issues, those may be the priority in the initial first month of life. However, one important thing to remember is that the cardiac surgery for shunt lesions or any kind of AV canal defect is usually performed a couple of months earlier in trisomy 13 and 18 because they are at high risk for developing pulmonary hypertension and vascular changes in the lungs sooner than patients without trisomy 13 and 18. If you have a patient with critical ductal dependent lesion and you have to wait for surgery because of other comorbidities, you can maintain the patient on prostaglandin. But in some cases, surgery has to be emergent or urgent. And in those cases, a decision has to be made whether your surgeon is going to do the surgery or there has to be some arrangement made for transfer to other centers where they may perform these surgeries. As I mentioned, there's a really high prevalence of pulmonary hypertension, varying degree of pulmonary hypertension in patients with trisomy 18 and 13. In my experience, some amount of pulmonary hypertension is universal. The reason for these are multifactorial, but a couple of the reasons that we know of are paucity and abnormal pulmonary vasculature. There is arterialization of the pulmonary vasculature. There is also airway and sleep abnormalities, which I will touch on briefly, but Dr. Green will go over in details. Dr. Carey, me, and one of my fellows, Liz Domingo, we looked at the Pediatric Health Information System database in 2017, and this was published in 2018, of the surgical outcomes, cardiac surgical outcomes of patients born with trisomy 13 and 18. And what we found was, not surprisingly, that there has been an consistent increase in number of cardiac surgeries performed in patients with trisomy 18 and 13. Obviously, trisomy 13 patients constitute a smaller fraction compared to trisomy 18. As you can remember from the prevalence data, that trisomy 18 is the prevalence is twice that of trisomy 13. So there were 195 surgeries performed from 99 to 2014. And you can see different kinds of surgery being performed. VSD closure, double aortic right ventricle repair, coarctation repair, and palliative surgeries. One thing I would like to emphasize here is there was a recent case in Stanford, which was published in Pediatrics. This was a single ventricle patient, and the surgeon in Stanford did not want to do surgery, but another surgeon did offer palliative surgery. So we are at a point in the care of these patients where I do not think there is any cardiac defects that is completely out of question in terms of palliative or complete repair. But these are the common repairs that are performed. If you look at the patient disposition or what happened to these patients, as you can see, the death or following surgery was 13%. Majority of them were either discharged home or to a chronic care facility, which is labeled as hospice in Pediatric Health Information System database. So the mortality was about 13% in trisomy 18. And if you look at trisomy 13, the mortality rate is about 26%. And this is consistently what we see, that mortality after cardiac surgery is slightly higher in trisomy 13 compared to trisomy 18. And if you remember the 15% or 16% number, that's the common number we quote. There's another study looking at kids inpatient database from 2006 to 2009, and they also looked at cardiac surgeries in trisomy 13 and 18. There were 14 surgeries in 13 and 34 surgeries in trisomy 18. And what they found was the length of stay was 2 to 4 times longer than someone who does not have trisomy 13 or 18. And the hospital charges were twice. So what we know now is after cardiac surgery, the mortality rate is somewhere between 15 to 20%, around 15%. But they do stay longer, about twice, and it does cost twice because of the comorbidity. Nothing surprising here. And adjusted odds of death were 4 times. We also looked at the SOFT database. SOFT database, the SOFT organization collects patient self-reported or family self-reported data from North America, and even some European data is here. And this was from 1990 to 2017. And what we found was very similar reports. This may be a biased data set because this is patient-reported data. But as you can see, majority of patients, 2/3 of them had complete repair, 14% had a CAT procedure, and about 10% had palliative procedure. Still, 2/3 of them had a complete repair of their heart defect. And the outcomes are defined in the registry as successful or unknown. And as you can see, majority of them had really successful outcomes as reported by the families. We found similar results, but again, in trisomy 13, I think the complete repair is lower and the successful outcome is also lower, but vast majority of patients did have successful outcome. Again, we cannot be sure about some bias because this is patient-reported data. More recently, this STS or surgical database, which is the National Surgical Thoracic Surgeons Database, was used to evaluate the mortality in trisomy 18 and 13. This is all cardiac surgeries performed across North America, and the data is fed into this database. And what they found was the operative mortality was 15%, very similar to what we found in our study using FIS database. However, they did find that mechanical ventilation was a risk factor for death. Unfortunately, I don't think it is causative, and it's an association, and I think, in my opinion, it's a red herring, but this is what they found. At least there was an association between mechanical ventilation and increased risk of mortality. The protective factors were presence of gastrostomy tube and prior cardiac surgery. Again, you can see from these factors that this seems to be an association rather than a causation, which is an issue with any observational study. It is hard to tease out causation and association. But again, the thing to remember is the mortality of 15%. There are multiple single and center experiences and small multi-center experiences that has been published in trisomy 13 and 18, and increasing numbers of papers from not only from America, but from Japan and other countries are talking about successful surgical management of patients with trisomy 13 and 18. And cardiac surgery is not, is something that is offered pretty frequently in many countries. So now we talked about how does the surgery matter? So this is a study looking at outcomes. This is a Kaplan-Meier curve, a survival curve, and you can see patients who had cardiac surgery, they had a significantly better outcome. This is a survival by percentage. This is 100% survival. 0% survival, and this is time. And you can see patients who had surgery had significantly better survival compared to those with no intervention or those who were maintained on prostaglandin. There's another study using the Pediatric Cardiac Care Consortium database. Again, similar data, Kaplan-Meier curve. You can see the survival is significantly better in those who were operated versus those who were not operated. And the survival in 35 infants was 91%. So two things we have established, that the surgical outcomes or surgical risk is somewhere around 15%, and operated patients do better than unoperated patients. Dr. Green will talk extensively about this, but this is very pertinent to cardiac care of these patients. There is a very high prevalence, and in my opinion, some universal presence of one of these issues in patients with trisomy 13 and 18. Upper airway obstruction is highly common, very common. Obstructive sleep apnea is not uncommon, and disordered sleep breathing is important to be ruled out. And we have to be really proactive to look at these issues and not just look at symptoms. Oftentimes, the symptoms are masked, and unless you investigate these, it is hard to find them. But it can have profound influence on cardiac care of these patients because, as I mentioned, pulmonary hypertension is extremely common in these patients, and one of the reasons for high prevalence of pulmonary hypertension and apnea is because of the upper airway issue. So we aggressively want to treat these before or after cardiac surgery to ameliorate the effects of pulmonary hypertension. I think the other question that comes to many physicians' mind is the quality of life. So our job is not only to improve the length or longevity of the patient's life, but the quality of life. So are we doing right by providing surgical care or cardiac surgery to these patients? And this is a very recent paper that was published by the Nebraska group, the Omaha group, and they're one of the pioneers in offering cardiac surgeries to patients with trisomy 13 and 18, Dr. Hamill's group. And they looked at the quality of life following cardiac surgery in trisomy 13 and 18. And they used a mixed method approach, and pediatric quality of life metrics specific for cardiac issues were used. And what they found was the parent-reported child quality of life was 80 out of 100, which is excellent. Very similar to someone without trisomy 13 and 18. And the parental quality of life was 78 out of 100, very similar to other chronic conditions and much better than what we anticipated. On a visual analog scale, this is the visual scale where the parents report how they feel. The quality of life metric was 93% or 93 out of 100. And on qualitative analysis, they found that the families felt a profound sense of value and meaning for life, and they felt like child's quality of life improved following surgery. And they would choose the same treatment course again if the options were offered to them. So what we discussed was that surgery improves the quality of life. Surgery does prolong life when performed in appropriately selected patient population. The dilemma of cardiac surgery in trisomy 13 and 18 still exists. There is always this conflict between the parents' wishes, benefits of cardiac surgery, and the risk and burden of treatment. And physicians often have to deal with this issue of thinking about how to not do any harm. And it is truly an ethical dilemma in these patients, because traditionally we have been taught in our medical schools, in our training, especially if you're trained 10 years ago, that cardiac surgery is not often offered to these patients, or in fact intervention is sometimes futile. But what I will tell you is that the attitude towards cardiac intervention in these patients is center-specific. Ethical dilemmas and bias is real. One of the reasons for this is this lack of large-scale outcome data. There is more and more outcomes data that is coming out, and people who follow this literature now understand that cardiac surgeries can be performed with very acceptable outcomes and low risk. There is bias due to outdated medical knowledge. There is one of the important biases that I come across all the time is bias based on neurodevelopment and cognitive outcomes of these patients. I mean, I tell families and parents and physicians that there is really no lower limit of cognitive ability or intellectual ability which precludes cardiac surgery. We should not offer someone cardiac surgery because of their intellectual abilities or what their physical abilities are. And I can show you that these bias exist. There was a very recent publication in Pediatric Cardiology. It was a survey of pediatric cardiologists, and they asked pediatric cardiologists whether genetic defect influences decision-making in cardiac surgeries. And these were AV canal repair patients. And what they asked was, if you have a patient with AV canal, with and without trisomy 21, will you mandate surgery? And in non-T21 patients, 84% of respondents or pediatric cardiologists said that they will mandate surgery. While if you have trisomy 21, only 54% will mandate surgery or advocate for surgery, a much lower percentage, even though the mortality following surgery is half in trisomy 21, 2.6% versus 4.44% in AV canal with non-T21. So even though the outcomes are better in trisomy 21, the advocacy or mandation of surgery is significantly lower. So genetic defects do influence decision making. There was also another survey of experience of families with trisomy 13 and 18, and 503 parents were surveyed. Response rate was 83%. And what they found was, when they asked about healthcare providers' attitude towards trisomy 13 and 18 care, at least they found 63% found that at least one provider was helpful. Some of them talked about, 60% talked about short, meaningful life. But what was surprising, that 87% of providers, 87% of the surveyed parents had heard from the provider that their child's condition was incompatible with life. 57% heard the baby or the patient would have a life of suffering. 50% heard the word vegetable used in reference to their child, and a quarter of them heard that the child, if you provide care, this will ruin their family. On the other hand, 97% of the parents thought that their child was happy, although 50% did admit that the care of their patient or their child was harder than what they expected. Lastly, talking about futility of care, I think futility of care in medical, in medicine is really a difficult decision because there is this issue of crisis of conscience. Oftentimes we are thoughtful about social justice, fair distribution of resources. But what I will say is the issue of social justice and fair distribution of resources are not a physician, decision. It's a societal decision. And if you ask our society in general, there is no question that the bias is towards treating patients and families and taking care of them rather than not. Quality of life is a value judgment, and it is best made by patients and families, not by physicians who see these patients in the worst of their condition when they are sick or in the hospital. The quality of life should not be compared to longevity of life or cognitive abilities, because we don't put much value to how long the life is going to be, but how good the life is going to be. Value placed on personhood is not based on intellect. My suggestion would be to engage with parents, colleagues, experts, and ethicists when you run across these dilemmas. So to summarize, decision-making trisomy 13 and 18 with cardiac defect, I think full disclosure of all treatment options are critical, both limits and outcomes. Again, what you need to do is to have an unbiased discussion about the data and what we know about the outcomes. Individualized care, not universally fatal or futile. Obviously, there are some patient population or some specific patients where the complication risk is significantly higher because of comorbidities, and they may not be a candidate for cardiac surgery. Respect parents' wishes and autonomy. Cardiac surgery is often not the most urgent thing. It can be delayed to post-neonatal period. Pulmonary hypertension sometimes can obviate the need for surgery in shunt lesion, which is pretty common in these patients. If a complete repair is not possible, catheter-based intervention or palliative care is an option with lower risk. There are increasing numbers of centers that are offering cardiac surgery in select patient groups, patient populations, and we saw that it improves survival. Surgical outcomes are acceptable, but worse than non-syndromic patients. The mortality is about 15%. Obviously, they have longer length of stay and cost. But most importantly, it is important to be compassionate and an advocate for the families and patients. This is Aaron Peterson, who I've taken care of since he was a neonate. He's now 7 years old, or maybe 8 even. And his mom says his trisomy 18 is compatible with joy, not just life. So take-home points. Cardiac defects are common, often complicated by pulmonary hypertension and airway and breathing issues. There are increasing numbers and complexities of interventions being performed across the country and in the world. Longevity and cognitive abilities is not the determining factor. Appropriate interventions do prolong life and improve quality of life. Quality of life is determined by the parents, not by the physician. Surgical risk in selected patients is really acceptable. They do need higher resources, longer length of stay. And lastly, seek help from experts in difficult cases. I would really like to acknowledge John and the SOFT organization and the patients and families who have really given me an opportunity to interact with this amazing group of patients and families. Thank you. John, should I stop sharing my screen now?
Yes.
Yes, please. And I failed to mention at the beginning for the audience that we were going to take questions from both of our speakers at the very end of the presentation. So make notes of your questions for Shaji. Now we'll turn things over to Dr. Green, and then we can ask both of them. Dr. Green is Professor of Pediatric Otolaryngology at University of Michigan.
It's a pleasure to be able to talk with you. I'll be talking specifically about airway interventions that we've been pursuing at the University of Michigan. These are predominantly related to trisomy 18, with very few trisomy 13 patients that I personally have experience with. But I think there's some valuable lessons here that can be applied both conditions. From a disclosure standpoint, I'll be talking about devices that are not FDA approved. I have patents related to some of the work that's been done, and I have also formed a company to help with some of these bespoke or customized devices. If we look at airway problems, if we go straight back to the initial description of Edwards syndrome, the very first patient was noted to have, during the first weeks of life, she had several cyanotic attacks. So breathing problems were noted right in the very beginning in the first article in Lancet. There was some dispute at that time persisting concerning whether it's chromosome 17 or 18. The chromosome anomaly of Edwards syndrome probably involves number 18. So this was even before it was known, airway problems were known even before the actual etiology of Edwards syndrome had been identified. This is from Smith's book, which was the main book that we used for giving ideas for different types of syndromes and genetic diagnoses. And in Smith's book, they said children may have apneic episodes. But when it looked at different abnormalities found in different percent of cases, pulmonary was not mentioned, just muscle hypoplasia of the diaphragm. Physical abnormalities in trisomy 13 and 18. Again, pulmonary abnormalities largely ignored. 90% of children dying within the first year of life present across both conditions. This is from a relatively recent textbook. This was advice given from one of a popular textbooks recently. The parents are told that normal development is dependent on a balanced set of genes, and that the baby has a genetic imbalance due to an extra 18 or 13 chromosome. They are then told at least 4% of recognized pregnancies begin with such an extra chromosome. Most of those with an extra 18 or 13 do not survive early fetal life and are miscarried. You must be very well suited for carrying babies to have had a baby with this extra chromosome who survived to be born. Although the baby survived intrauterine life, its capacity to survive outside of you is limited. If we intervene and try to prolong life, the baby's function will be extremely limited. We feel the kindest approach is to let nature take its course by not intervening from the medical standpoint. Do we have your permission for this approach? Thus, the parents are told the basic cause of the problem, help to interpret the situation as a late miscarriage, and given the option of no medical intervention. 95% of children were estimated to die within the first few weeks of life from either cardiac failure or respiratory distresses or apnea. So in contrast, at the University of Michigan, we have 65% one-year survival. I had the people pull my personal survival, and 26 out of 28 patients where I was a consulting physician have survived. So we can have extremely high survivals. This survival during the early period is dependent upon aggressive respiratory intervention. So airway obstruction in trisomy 18 is the most common cause of death in the first year of life. Dr. Meenan, I really appreciate his talk and the way he discussed how the respiratory issues tend to be bigger. We're also very aggressive from a cardiac standpoint, but it tends to be the respiratory issues that are the early problems. Children with trisomy 18 without airway obstruction, without significant cardiac disease, are known to live long-term. If the airway obstruction and the cardiac diseases are treated, long-term survival is expected with a mean follow-up of 5 years. So when should we evaluate for airway obstruction for children with trisomy 18? Nearly all children will have some degree of obstruction. The things when we recommend an evaluation is if the patient is noted to have any snoring or stridor, meaning there's any noise with respiration. We recommend evaluation if there are any pauses in breathing or gasping episodes noted, that mean obstructive or central apnea is noted. If retractions are noted in the patient, or if they are undergoing general anesthesia for any other reason. Children with trisomy 18 are very difficult to intubate during the neonatal period. A lot of this is related to the small jaw that these children have. The average grade is 2.66 plus or minus 0.77, with grade 1 being a normal airway and grade 3 being an airway that would require expert anesthesia intervention. Of particular interest, glide scopes were unable to improve intubation success, and the way that we were able to have the best intervention as far as succeeding in obtaining an airway, a surgical airway for these children, was with the Hollinger anterior commissure scope. ENT intervention was needed for half of children undergoing cardiac surgery or other surgical intervention. Of children that had a sleep study, 48% had obstructive sleep apnea, 2 with moderate obstructive sleep apnea, and 12 with severe obstructive sleep apnea. The mean apnea-hypopnea index, which for a child should be less than 1, was 31.8, with a range from 3.1 to 83.4. So we're looking at children where it's very common to have extremely high rates of obstructive sleep apnea. There are a number of reasons for this, but the initial workup for obstructive sleep apnea is we tend to go to DISE. And I'll discuss that later. Children that are known to be at risk for refractory obstructive sleep apnea after tonsillectomy and adenoidectomy are children that have obesity, small tonsils, severe baseline obstructive sleep apnea with an apnea-hypopnea index greater than 30, chromosome abnormalities, hypotonia, and craniofacial disorders. So if we look at children that have trisomy 18, obesity generally does not apply, but every one of these other factors tends to apply to children with trisomy 18. So the simple, regular methods for intervening for obstructive sleep apnea, namely tonsillectomy and adenoidectomy, it tends to be very ineffective in this age group. So the hypotonia is one of the causes, the small jaw in particular of the craniofacial disorders, and small tonsils are also noted in these patients. This is a video of drug-induced sleep endoscopy. This is the intervention where we go to the operating room. We have the children go to sleep with medical cocktail. Dexmedetomidate is the most common medicine that we use. And then we'll pass a fiber optic scope through the nose to examine the airway while the child is sleeping. This is a child with trisomy 18. And as we look through the airway, there's some things that we'll notice. The first is that the palate tends to be hypotonic. And you can see the palate going against the posterior pharyngeal wall. As we come further along, we see the base of tongue collapsing. This is the base of tongue in this region here. And as we go further forward yet, we'll see posterior epiglottic collapse. And so we see the epiglottis pushing against the posterior pharyngeal wall. And here we can see the tongue base falling back against the posterior pharyngeal wall. And then we have the epiglottis. And so this child is breathing through this very small opening here. And this is why we'll tip it. And this is with the jaw thrust. You can see with the jaw thrust, there's marked improvement in this one particular child. And you can see the full airway with the jaw thrust. And so this is a common situation for children where their jaw is too small. And so interventions that can be done, and again, this is with the jaw thrust, then we see the airways much more open. So mandibular distraction in particular can be helpful where the mandible is the main problem, or this whole area can potentially be bypassed with the tracheostomy. But at any rate, the hypotonia associated with trisomy 18 does cause tongue base and palatal collapse, which can sometimes be effectively ameliorated surgically, but sometimes not. So the pharyngeal obstruction that we see, we talked about tongue base, palate, and micronathia. The definitive operation for this is to bypass this entire area, which is a tracheostomy. This is a tough decision for parents to make, whether they want to have this level of intervention or not. Adenotonsillectomy, pharyngoplasty, and mandibular distraction can all be done shy of a tracheostomy in an attempt to decrease the amount of pharyngeal obstruction and get the child to a situation where they'd be able to go home. This is a picture of the palatal collapse again, and the tongue base collapse that we can see. Epiglottic collapse is often seen. And then here's a picture of even worse epiglottic collapse in trisomy 18. Here you can see the full epiglottis collapsing back against the posterior pharyngeal wall. And so this is obstructive sleep apnea, which is, you can see how it's completely collapsed at this point. It will resolve with jaw thrust or doing something to bring the mandible forward, but traditional interventions like tonsillectomy and adenoidectomy are completely ineffective in a child that has severe epiglottic prolapse. And so for this reason, as a general rule, we recommend sleep endoscopy prior to surgical interventions from a planning standpoint. So we've been doing some things where we try to go and identify what kinds of of things that we can do to improve the quality of care for these children. One of the things that, and shy of a tracheostomy, so one of the things that we've been working on is a nasopharyngeal airway. This is what's used in London for a lot of children with micrognathia where they don't want to pursue mandibular distraction. And this is something that we've worked on. And nasopharyngeal airway in selected patients can be very helpful. The length needs to be extremely well customized based on where the tongue base collapses and what's going on with the epiglottis. We've also made a customized CPAP mask. This is a child with Treacher Collins, but it demonstrates the principle where we'll take a scan of the face of a patient, and from the picture of this patient, we'll go and design a custom interface that allows a regular CPAP. So in contrast to children that have normal sized jaws, children with small jaws will have difficulty with normal CPAP masks interface. So bringing the jaw forward or having a customized device can be very helpful for this situation. And this shows the child with the 3D printed mask. Here's the actual mask interface placed in the mask that was used. Tracheobronchomalacia is one of the most important factors in persisting obstructive sleep apnea or persisting breathing difficulties after tracheostomy. Tracheobronchomalacia is where collapse of the airway persists in the trachea and main stem bronchi. This is very common in children with trisomy 18. So even when a tracheostomy is done to alleviate obvious and severe upper airway obstruction, there can frequently be problems down lower. To treat severe tracheobronchomalacia, you can try, in milder cases, they can respond to an aggressive pulmonary regimen, but in severe cases, a ventilator for increased positive pressure is what is necessitated to help these children out. Central apneas can also exist. A sleep study can differentiate obstructive and central apneas. It's important to note that when there are obstructive apneas, frequently we'll see improvement in the level of central apneas by removing the obstructive component of the sleep apnea. But it should be pointed out that a tracheostomy is not definitive for the upper airway obstruction in children with trisomy 18. We developed a device that can specifically treat severe malacia that goes around the outside of the airway. We did mechanical testing and we're now about to enter an FDA trial for this device, but we did have one child with trisomy 18 where it was actually due to a translocation in the chromosome, and multiple family members had died from this. Even after a tracheostomy and being on a ventilator, the level of tracheomalacia continued to result in recurring death episodes. And so it's important to note that tracheobronchomalacia will frequently present as episodic death episodes and apneic episodes that require positive pressure or bag mask ventilation to break the child from. So this is something that's commonly seen in the post-op period and is in kids with trisomy 18, and is a warning sign that there may be severe tracheobronchomalacia in addition to baseline obstruction. For this child, we were able to intervene, and after the intervention, we were able to go and take the child off the ventilator, no longer needed ventilatory support, and did not need a tracheostomy. So this shows before and after of reconstruction with the splint in place. I'd like to comment a little bit on the voice in trisomy 18. Many of these children are able to phonate. Children will rarely have 1 to 2 words. It's presumed to be a cognitive problem. Many of the children are able to understand much more than they're able to say. Hearing in trisomy 18, most children with trisomy 18 have normal hearing. Music appreciation is extremely common in older kids, where the children will have favorite types of songs that they like. They will beat and rhythmically and dance to music as they become bigger. And so this is a very enjoyable part of their lives. And it's really fun to watch the kids smile when with music. So with the very small ear canals that these children have, typically 1 to 2 millimeters, it's frequent that the strumen will be trapped. However, middle ear disease is rare. It's often assumed to be common, similar to trisomy 21, but it does not appear to be the case. And so we have in particular found that trisomy 18 is much narrower than even Down syndrome from an ear canal size, and bone conduction hearing devices may be very helpful for these children as far as giving them hearing and music appreciation that they might not otherwise have. So I want to go in and just close by saying that our recommendation is for customized interventions based on what's specifically seen in the children. These are best done based on results of sleep studies and sleep endoscopy, as well as examination of the distal airway. Tracheostomy is a definitive intervention, but except for when there is severe tracheomalacia and bronchomalacia, in which case ventilatory support may still be necessary. So it's a pleasure to be able to talk with you today, and we look forward to answering any questions that you all may have. Thank you.
Thank you, Dr. Green and Dr. Menon, for speaking for us today. We really appreciate it. And like Dr. Green did just say, if you have any questions, feel free to use the feature where you raise your hand and we'll allow you to speak and ask your question, or you can type it in the chat.
While we're waiting there, Kelly, I wanted to acknowledge you and Terry for orchestrating these 3 sessions and for putting it all together. So we thank you for that.
You're very welcome. We're very, very happy to be able to bring this to the soft community and to the professional community. It's really, we appreciate everybody's time on this.
So Glenn, I have a question, if I could. You know, just your presentation of the endoscopy showing the palatal collapse, you know, as well as, you know, the glossoptosis. Do you think for all the years that we said most of the infants with trisomy 18 died from central apnea, that there was a lot more upper airway issues that we probably didn't discern?
I think that is very much the case. The central apneas have been described as, if you look at the literature, some of the older literature, they said central apneas were the problems. However, obstructive apnea, in contrast to central apnea, is marked by retractions, which have been known, which you know, they're very common in these children, by stertor and stridor, or the breathing sounds, which are central apneas or absence of the central drive. And so I think there's been a marked underappreciation of the degree of obstruction. Specifically for palatal obstruction, I've done just palatoplasties, aggressive palatoplasties on some children that did not want to have tracheostomies. We're able to get them home with more oxygen support than they might have otherwise needed, but they have been able to do well with just addressing the palate in at least 2 cases. So in contrast to a normal a situation where we'd expect a typical child to go home after palate work, maybe 1 to 2 days afterwards, kids with trisomy 18 often will be in the hospital for 2 to 3 weeks afterwards due to some of the concurrent other levels of obstruction. And so it's, again, the care afterwards is complex for these children. Just as Dr. Menon was saying, It's multifactorial. We have cardiac and multi-level obstruction. And so it's not these kids are not straightforward, particularly during the early postoperative period. These kids can appear to be doing well and then have sudden dying episodes that require early and aggressive intervention. And so this is not to be looked on as something to take on lightly, but the children can do extremely well afterward. And I'd also like to say, even though a child is generally doing well from a respiratory standpoint, these kids, when they get colds, often will end up back in the hospital. And particularly, we're talking about COVID and things like that now. And I'm advising the patients to try to avoid COVID-19 as much as possible for these children that have much more difficulty and are much more likely to end up in the hospital in the intensive care unit than a typical child.
At University of Michigan, are you called to see, or you or one of your associates called to see every newborn with trisomy 18? Is that routine in your NICUs now?
And it is not. And so it's they ask the parents whether or not they want to intervene. And if the parents do not want to intervene, then we are specifically uninvited from participating.
One reason why I wanted you and Dr. Menon to speak together is I think, and you were in, Shaji brought together talking about the airway related to pulmonary hypertension and so on. But I think it's that complex of cardiology and secondary effects and the upper airway issues, I think that are what need more further in-depth study, both in trisomy 18, especially, both 13 and 18, but especially 18.
Yeah, I very much agree with that. And of the children where ENT was did not participate, mortality was extremely high and often very quick.
I mean, one of the frustrating parts about taking care of patients with trisomy 13 and 18 is there is really a wide range of expertise and knowledge about these patients among caregivers who are taking care of these patients, which can range from expert knowledge to very wrong kind of biases and knowledge. So that really colors the way these patients receive treatment. And I have emphasized this to John and others in our hospital that it may be beneficial to have a more comprehensive discussions and identifying a group of experts who are actually committed and who keep up with the literature in the field, so that we can actually make decisions based on what data is out there rather than conjecture, biased opinions. So as you said, oftentimes you are not part of the discussion. But even when families decide to go with comfort care or palliative care, it may be worth having a discussion with all the providers who know what's really needed for that child, experts.
One thing that I would like to mention is that often when we talk about tracheostomy and ventilator, that type of situation, people think of that as being akin to something that's end of life, something that an old person where grandpa is about to pass away and he's put on with no hope for survival. And this is an entirely different situation for these kids, where despite being on a tracheostomy and a ventilator, they're able to be at home, they're able to interact with their family, they're able to enjoy music, they're able to be fully awake and cognitive and involved. We see that at the Trisomy 18 conference a lot, but that being said, when you have somebody that hasn't had a chance to go and see what the life is like for these kids, it's easy to think of that as something to be avoided at all costs. And so I'm more than happy to go and intervene and do what we can shy of that. And frequently we're able to make enough interventions to help them out. But in some of the most severe kids, they really need full intervention if they're going to survive.
Kelly, are there hands raised, or are we answering all the questions?
You guys are doing such a great job that you have answered everyone's questions. I don't have any hands raised or anything in the chat.
You've left them speechless.
Yes.
Shaji, I appreciated your slides, especially when you were talking about the futility issue, when you brought up Dr. Weaver's, who's speaking tomorrow, by the way, quality of life study. Appreciated all those. And even in the beginning, the laying some of the biases and prejudices right out on the table. I think that's that sort of view, and you spelled out what we do know a little bit about, hearing from the parents. But I think that's the world view that needs to be on the table. Both sides need to be heard and, needs to be addressed. I appreciate your putting it all out there, for a continued discourse.
Yeah, I completely agree. Some of these topics are touchy, because they generate a lot of emotional outbursts because people are on one side or the other. Sometimes they have their own belief system, and often these challenges those belief systems. So I think these discussions, although frank, need to be held in an environment of understanding and ultimately patient-centric and family-centric, focused on the family rather than what we believe in.
One body of literature I've been tapping into lately but haven't finished going through is this, mostly around kids with cerebral palsy and other neurologic disabilities, that when you ask them their perception of quality of life, it's actually better than people perceive. When you ask the parents, they actually perceive themselves better than the parents think they're doing, and the parents perceive their quality of life better than their doctors and other healthcare providers. So there's this continuum. So I don't know how to apply that exactly to trisomy 13 and 18, because we know they probably understand more than as a group than we think they do, but the issues of the cognitive issues make that harder to discern, but I think it applies.
Right.
And certainly these kids with trisomy 18 do much better than a child that's profoundly brain damaged with cerebral palsy. They're much more interactive with their families. They're much happier, smiley kids all the time. You can tell that they enjoy life. And they're generally a blessing to their families. And so it's distinctly different than the kids that have anoxic brain damage, for example.
I mean, there is a stark difference between what many physicians or healthcare providers think about their quality of life and what the families perceive. And that is, evident from multiple studies and surveys. I think there is a real gap here that needs to be addressed in terms of the quality of life issue that people think about is not based on their personal biases, but what the family think. And families' experience have anecdotally and based on the studies been very positive.
And I think just from my own standpoint, I think it'd be very helpful for families to go and make videos.
Right.
Some of those kind of things, some pictures and things like that are available online, but to have some videos of what life is like for some of these families, I think would be extremely helpful for someone that's trying to figure out what actually ends up on the other end when they're considering interventions.
John, I just want to take a moment to talk to the SOFT organization here. Like, there are other organizations that I work with, like Hypertrophic Cardiomyopathy is one of the organizations I closely work with. And they do have these centers of excellence that they have defined where you need a minimum amount of expertise and knowledge to take care of patients who have hypertrophic cardiomyopathy, because they need this multi-speciality care. And I don't think trisomy 18 or 13 care or trisomy babies with trisomies are no different. They require a high level of expertise, and this may be an opportunity to think about what constitutes a trisomy friendly hospital or a trisomy friendly center that parents can lean on or use as a resource, because it's not something that everyone gets to do, right? Like Dr. Hamill does trisomy surgeries, multiple surgeries every month or a year, while many surgeons do it once in their lifetime. So their experiences are very different.
Thank you, Shaji. So you do have two members of the board here with Kelly and Terry listening in. I have brought up your idea before. I have to say, though, that I didn't carry it forward to then implement it and make it happen, because I think, as you pointed out, the idea of coming up with criteria and defining a center of excellence is something that we would do. I say we in the sense of also being on the board and working with our scientific and medical board. But again, Terry and Kelly, keep this idea that Dr. Menon has been mentioning to me for at least 2 years. It would actually come from SOFT. It wouldn't come from the cardiology, ENT, or genetics community. SOFT would have criteria. One meets this criteria, they would be deemed a center of excellence. And as Shaji pointed out to me, that moved care along in cardiomyopathy. And so again, we're having a board meeting next week virtually, but I think we should have our board members hear what he just said at the end of his video. We can talk about it. We are past the hour. I know that Zoom isn't going to kick us off, but I think if there are no other questions, maybe I'll sincerely thank our organizers, Terry and Kelly, and also Dr. Menon and Green. But anyway, again, we thank our organizers and our outstanding speakers for joining us today.
Thank you, Zan. Thank you, Mary.
We appreciate everything. Drs. Menon and Dr. Green, thank you so much. And Dr. Carey, of course. Thank you so much for your passion for our children. As the mom of a 20-year-old with a trach, trisomy 18 with a trach, this is a conversation that couldn't have taken place 20 years ago. You guys are pioneers and you're making changes you're creating a wave that's creating attention for our kids, and it's making a huge difference, and we appreciate that. We appreciate everyone joining us today. We'll be back tonight for those SOFT members for our SOFT Friends video premiere at 6 o'clock Central Time, and tomorrow we'll be back at 12 noon with Dr. Steve Cantrell, I believe. Go to trisomy.org for all of the happenings and register for whatever you are not registered for. We appreciate everyone. We'll see you online. Take care. Bye-bye for now.
Thank you. Have a good one. Bye.
Thank you, guys. Appreciate you, doctors.